Amblyopia is a very, very important, and I think even if you don't deal with children, I believe that everyone should know how to deal with amblyopia. So Dr. Resmi is going to enlighten us with newer methods of amblyopia treatment.
Thank you, ma'am. Good morning, everyone, and my topic is what's new in amblyopia treatment. No financial interest or affiliation to any of the product mentioned here. Amblyopia is a disorder of neurodevelopment that results from inadequate visual experience during the early years of life, that is, during the critical period. It's the most common cause of monocular visual impairment in children. For a normal visual development in a child, you need a visual stimulation, ocular alignment, and a clear visual image. If any of these is disrupted, it will result in amblyopia. We know that the amblyopia causes a decrease in vision as well as a decrease in contrast sensitivity. What are the functional consequences? There is a fellow eye deficit in the form of impaired motion perception, fixation instability, and 25% slower reading than the peer group, and impaired motor skills like poor hand-eye coordination, and all this is going to affect the quality of vision and life of a child. Awareness and screening is the first thing in case of amblyopia treatment. The neonatologists, pediatricians, and all healthcare professionals should be aware of the condition and start early screening and detection. At the time of birth itself, the retroflex can be checked and external eye for any other abnormality. All preterm children, in addition to having an ROP screening, should have a refraction and squint evaluation at 6 months of age, and here a follow-up after that. And those with a family history of refractive error, squinting, or amblyopia should have early screening. With all the newer advances in screening methods, like already mentioned by Dr. Chaitanya, all children before they start their schooling should have a vision test done. Coming to the amblyopia treatment, it will start with the correction of the refractive error or squint if any, and correction of the visual deprivation factors. Refractive correction alone will solve the anisometropic amblyopia in 27% patients. And for bilateral refractive amblyopia, 74% achieved best corrected visual acuity of 20/25 with glasses alone. Even in strabismic amblyopia, 32% had a full resolution with glasses. Coming to amblyopia treatment, we can divide it into monoocular or binocular. Monoocular treatment, what we know is about occlusion or patching, atropine penalization, and Bangerter foil. Atropine, regarding the patching history, it starts from around 900 AD, and it has been continuing from 16th century for treatment of squint. And till now, patching or occlusion therapy is a main important thing for all patients for amblyopia treatment. Different types of patches are available, like those adjacent to this directly, which is adherent to the eye, or those worn over the spectacles, and depending upon the creativity of the parent, you can see different methods of patching. So whatever we know, we know that the patch is still our all-time hero. Coming to pedic studies by the amblyopia treatment trials, patching is effective. For mild and moderate amblyopia, 2 hours of patching is equivalent to almost 6 hours of patching, and severe amblyopia, 6 hours of patching is equivalent to full time. And up to 17 years, patching alone has been shown to have improvement if previously not done any treatment. Disadvantage is poor compliance, skin allergy, and you need a good parental support. With a new academic career and all, they don't find time for patching at all. And in some cases, they have occlusion-induced amblyopia also. The new thing in this patching is monitored occlusion. There are a few sensors attached to behind the patches by which we can directly monitor the compliance and number of hours of patching. Intermittent occlusion glasses, that is a liquid crystalline glass that we can set the timing of occlusion, that is the glass will suddenly become opaque without the child knowing, and you can set the eye and also the hours of occlusion. But because of its high cost, it has not gained much popularity. Occlupad or occlutab, by removing the polarizing film layer from the LCD screen, the amblyopic eye will be able to see through that, and the fellow eye we are given neutral density filter. The new perspective in amblyopia is treatment of amblyopia outside the critical period. We know adult brain can learn after injury. So the plasticity at the cellular, synaptic, and cortical level is the one that is preventing the amblyopia from improving the adulthood. Certain factors like intrinsic and extrinsic factors that change the plasticity, then amblyopia treatment can be given to adults also. The second important thing is amblyopia is a binocular disorder. We now know the higher order functions are affected in amblyopia. So the treatment also has changed from uniocular to binocular level. Binocular therapies are 2 types actually, perceptual learning and dichoptic training. So what is perceptual learning? It means if you repeatedly do a thing, that can produce a change. That is, practice makes perfect. Perceptual learning is based on visual stimulation and neural plasticity by targeted visual exercises. You keep on doing like number recognition, contrast identification. These when you do repeatedly, it can cause a change in the plasticity. Disadvantage is boredom. If you repeatedly do the same thing, they will get bored. And improvement in specific task only. Revitalization is one such which is based on perceptual learning. Dichoptic therapy, it is based on giving two independent stimuli to each eye, and you increase the signal in the amblyoptic eye and decrease the signal in the fellow eye. So, when the child uses both the eye only, they will be able to play. Different types of dichoptic therapy are there, and the child uses anaglyphic glasses, and they are doing high contrast is given to the amblyoptic eye, and they play the games or they watch movies. They can do it in tablet or computer screen. It can be home based or in hospital based. Few studies have shown that they show an improvement within a shorter period, but long term, not much proof. Orthoptic is a magnocellular stimulated by our own Dr. Santan Gopal sir. Depends upon the top-down impulse, and it depends on the stimulation of the attention mechanism. The child will be counting the number of lights in the periphery or the lights that is shown on the screen. Now, the new thing is a virtual reality games. That is, a child uses a VR headset, and they will be two images will be given to them. You can adjust the contrast of the image by increasing the contrast or decreasing the contrast. And the new Amblyopia trial study has shown that VR game of 1 hour, 6 days versus 2 hours of patching. The results are yet to come. What are the advantages? It improves the vision, stereopsis and binocularity in a shorter duration and better compliance that as the kids are easy to play. And the disadvantage is cost and balancing the therapeutic with the digital media and screen time. Because once they started doing the games and all, later they can go for an addiction to it. And it's not suited for dense amblyopia and very young child. Coming to pharmacotherapy, two drugs which are commonly used are levodopa-carbidopa combination, which increases the dopamine level, and citicoline also. It increases brain metabolism and increasing the norepinephrine and dopamine in CNS. The studies have shown that citicoline with patching has shown better results than patching alone. And levodopa for the residual amblyopia is also under studies. Another new thing is transcranial magnetic stimulation. By stimulating the occipital, it will change occipital cortex with the magnetic stimulation is shown to change the plasticity and work in adult amblyopia. So the take-home message is early screening and detection of amblyopia plays a key role. Correction of refractive error and amblyogenic factors is essential. Patching still plays a very major role, and amblyopia have a role beyond treatment have a role beyond the critical period. Dichoptic therapy can be combined with patching for better rest, and with the ongoing researches, we hope for an ideal and better method that can be applied for all ages, severity, and types of amblyopia. Thank you.
So, thank you, Dr. Resmi. And so, still, we have been talking about occlusion in amblyopia for many decades now. Still, it holds good, but we have come a long way in how we manage children with occlusion. And the other good thing has happened in the recent years is we have all these things. With children, the problem is to make them do these exercises. Now that all these things have become playful, things have become easy, and the management scenario of amblyopia is totally changing over the